Okay, if everybody's ready, we're going to go ahead and get started with the ERT Roundtable. What have we learned? And this is, kind of a new experiment for us, having a roundtable session like this, but it's something I'm really excited about. I mean, the truth is that we're at a point where ERT's been approved since 2006, but it's been in clinical trials since 1999. So amongst some of the experts here, you've got 16 years of experience with enzyme replacement therapy. That's a lot of experience, that's a lot of knowledge, and so what we're going to spend the next hour doing, and then the hour after that, is having some of those experts who've been really working at it since the very beginning, talking about what we've learned, what we know now we didn't know then, what we need to do going forward, and really some of their different approaches to treating patients. Because many of us here may have a doctor that has one patient or two patients. Not many of us go to experts like these. So I think it's going to be a fantastic opportunity to learn straight from them, and then to really spend the next hour asking any questions we have. So with that, we're going to go ahead and get started. We're going in alphabetical order. So we're starting with Dr. Chen from the National University of Taiwan. So thank you, Dr. Chen.
Thank you, Tiffany, to give me this opportunity to hear. And since I'm the first time here, and per Tiffany's request, I need to introduce you myself about my story related to Pompe's disease. And here you see that I'm from National Taiwan University Hospital from Taipei, Taiwan. And if you know Dr. Y.T. Chen, that this is the medical school he graduated, so this actually is our relationship to him and the initiation for the further story. So I'm work with Paul Hu here. Probably you know know him, and our very good skill medical technology technician Sarah Zhang. And I want to share with you 3 points about our hospital. And it has been founded for more than 100 years. And at that time, that was the largest and modest one in Southeast Asia. So our hospital actually have many referral, especially the rare disease patients. And that's the reason back into 1990s, when Dr. Paul Hu came back to our hospital, he established the biochemical lab, especially for these lysosomal storage disease patients. In addition, our hospital also ran the newborn screen center almost 30 years, and it is the first one in Taiwan. So because I'm standing at this hospital and we have these 2 advantages, that's the reason why later we try to do newborn screening for Pompe's disease. And for those who don't know where Taiwan is, we are besides China, and we are very small sweet potatoes here. So although we are very small, actually we have a huge populations, and by incidence we have almost 4 to 5 infantile patients every year. So this is the first story that I want to share with you, that we initially contribute around 1/4 of patients in this natural history study. So as I say that Paul established the enzyme measurement in our hospital, and when Dr. Y.T. Chen came back to Taiwan in 2000 And two, this couple, they found their boy have this infantile onset patients, and he found that Dr. Y.T. Chen came back to Taiwan. So because of their efforts, we have this baby treated in Taiwan back to that times. So it is the reason we participate later the natural history study and then the pivotal clinical trial in infants. And you might know that we have a very good improvement in survival based on the pivotal clinical trial study. But at that time, actually, we worked very hard to keep them non-ventilator. So we noticed that even those infants have the treatment, their outcome is not good enough. So we try to have the diagnosis earlier. The most easy way is to do newborn screening. So we start newborn screening back into 2005. And then, the Myozyme approved, and then the Lumizyme just approved. So we have those activity related to Pompe's disease. I want to show you this is our effort in Pompe newborn screening. Although it is a quite easy idea, actually we have made some efforts to make that technique into real world. So initially we adapt Dr. Tromoli's method to measure GAA activity from dry blood spot. We think that is an easy way, but we need to test in a large population. After we do that, we found that although we can identify patient very earlier, but we encountered some problems that is we call pseudodeficiency allele that will make this newborn's activity quite low, but actually they are not patients. So we spent some time to clarify this point, and we build up our experience so that we can have more confidence to say that this newborn, although they have low enzyme activity, they are not patient. And we need to prove that through newborn screening, they can have better outcome. And I think another major point is that we detect enzyme activity. So we detect both infantile, the severe form, and also the other end of the spectrum that we call late onset or late onset patients. And we need to find a way to monitor them and to find a way to decide when to start the treatment. So I just want to show you that we spent 10 years from the initial to this year that in the United States, you formally put Pompe newborn screening into the recommendation uniform screening panels. So it's been a lot of efforts here. You already seen this before that only with enzyme therapy, we can save many infants here in the green line compared to those children without treatment. But only we added newborn screening to detect those babies much earlier, so we can provide treatment by age 1 to 2 weeks. So they can have this survival curve. Now every child survive, and they don't need ventilator. So this is current my patient, Valen. We have still some infantile patients identified by their symptoms, we call clinical cases, and still alive. And we have some newborn identified through the screening, and all of them now are alive without ventilator. We also have some late onset patients, majorly come from newborn screening because I'm a pediatrician and I run a newborn screen center. So we have some newborn cases. Now, some of them already on treatment, but some of them are still on monitor without intervention. So this is our current algorithm for those positive for newborn screening. We found if they have very low enzyme activity at, we call the first dried blood spot, that's usually taken at age 3 days. If we notice that the enzyme activity is very low, we will ask the baby come to our hospital to check if they have cardiac involvement. And at the same time, we will do another GAA activity measurement. Now is from the lymphocytes, and we also do the genotype. But you know the genotype needs some time, so we can check heart involvement immediately to see if they have a big heart. If they have a big heart and compatible GAA activity, we will start enzyme therapy immediately. But if their heart is normal, we will wait for the enzyme activity as well as the genotype to see if they need further follow-up or if they don't need further follow-up. If in this group, we will do initially every 3 months follow-up, and then probably 1 to 2 years follow-up if they grow older enough to see if there are any symptoms indicate that their muscle has been damaged. So we need to do enzyme therapy. So this is our previous experience that actually the big heart can be detected at birth. So everyone, if we see this big heart from the chest X-ray, we will start treatment. So after treatment, their heart size significant decrease and remains normal. But I need to say that we have some residual problems in those babies. The first one is the elevation of creatine kinase, CK. So initially, their CK may drop very beautifully, but then the level just went up. The elevation of CK actually translate into their motor function impairment. So although those children still have some motor development, but the gap from the normal children here, you see the gap just enlarged within times. So we think that the treatment may need further improve to help in this part of a problem. The second, so you see, this is our patient now at age 8 years. She needs some help to climb stairs, and those parents actually are a little bit worried about if she will need to have a wheelchair some later times. The second problem we observed is the white matter disease that you already know this morning, that those babies, although they have been treated very early, they still have some brain image abnormalities. This is a normal baby. You can see the black signal here that is normal. So in this film, you see the white signals, the white signal. This one is better, and this one. So we think this is the second problem we observed, but actually this one and this one has very good school performance. So we think this might be a concern, but not immediately threaten their quality of life. Other things actually has been observed by Erasmus group and by Duke group. That is, they have ptosis. So we have this chance to do muscle biopsy from their eyelids because this boy have ptosis and need surgery. So we see that the muscles still contain many glycogens here. And the last thing I want to say is that they all present speech quality problems. So they have very severe hypernasality, and their sounds are very wet. And all of them have facial muscle weakness. They don't have very much those nasal folds. I think we are lucky that all of our patients don't have too much problem related to antibodies. That is because our population is quite homogeneous. We have this common mutation. So they are CRIM positive cases. And you can see very robust response. This is antibodies titers. So every one of them can have tolerized around 1 year of treatment here, except this one. But you see here that she's been tolerized after 2 years. And here you can see the dashed line and the solid line indicate the clinical cases that they have been treated since around age 2 or 3 months of old. And the solid line indicate our newborn screen cases. They have been treated around age 1 or 2 weeks. There's no difference in the antibody titers, the time to produce or the highest titers. So there no difference. And we have this one have infusion at age 1 week. And you can see this one, the orange one, don't have too much benefit from very early initiation. The last thing I want to say is that because we observe their muscle weakness and their elevation persists their CK, so we try to increase the enzyme therapies, either increase the dose or increase the frequency. At that time, because you see the reimbursement issue, so actually we struggle a little time to increase these cases. But now we try to do that earlier. At this time, I cannot conclude if the double dose will be help. But I think some later the speaker will talk about that. Okay, so this is my experience.
So I'm going to follow up based on the advice given by Tiffany on who each one of us and what our institutions bring to the table. So I was just looking at the heritage or the pedigree. So this is from Duke University since 1961. You can see a number of individuals in the room and a number who have made major landmarks and contributions to the field of the glycogen storage diseases, including Pompe disease. So I also was asked by Tiffany to put in perspective our university's contributions to research in the field of Pompe. So I want to clarify that this has been a collaboration across the world, but I was just going to highlight some of the sections as done at Duke. And so the genetically engineered CHO cell lines had started in 1991 at Duke, and then the showing that the CHO cell line worked in vivo via the quail bird model was done. And then in 1997, Duke was able to obtain the FDA orphan drug designation status for enzyme replacement therapy. In 1999, the CHO cell trials had started at Duke as the single trial with 3 babies. And then moving along is the contribution to the natural history study, which ultimately was used as the comparator group for the pivotal trials which were done in the infant studies that were to follow. Then the development or the utilization of urine hex4 as a biomarker for Pompe disease was spearheaded by David Millington and Sarah Young at Duke. And then playing a role with many, many other individuals in this room in getting Myozyme approved in 2006. Then in 2010, this work had been ongoing, but the recognition of CRIM-negative as a poor prognostic factor for Pompe disease was recognized. And then the following year really showing that it was not only CRIM-negative status, but really having high sustained antibody titers is what really was the poor prognostic factor. And then moving along was the successful use of immune tolerance induction regimens in CRIM-negative babies and high-risk CRIM-positive babies. And in the naive setting, so at the time of start of ERT, but then also being able to show that those individuals who had already developed high and sustained antibody titers, we had found a way now to bring the titers down and actually to tolerize those individuals. Then in 2012, starting work on the role of beta-2 agonists to enhance the efficacy of ERT by upregulation of M6P receptors. And actually this work had started from 2006, trying to submit information to the Secretary's Committee for putting Pompe disease on the newborn screening panel on the RUSP. And so I remember submitting this in 2006, getting 3 rejections and going back. And I want to take this moment to thank Tiffany from the AMDA for her support in finally getting this as a joint effort in 2015, where today Pompe disease is now on the RUSP and approved by the Secretary's Advisory Committee. So technically, states can now start implementing this by doing newborn screening. And now working very closely, this is something which has been my passion with the FDA on a guidance document which is to be published in the next month on the role of immune tolerance and its need in Pompe disease. So as I state this, I represent my institution and also many other members from this community. But these have been our contributions and what we call a T1 to T4 approach. T1 to T3 is what we call the bench to bedside, and then T4 is back to community health or public health, which is newborn screening. Tiffany then asked me to just mention, so we've been involved in clinical trials and clinical research and bench research with Pompe disease. Participated in more than 30 trials, many of which have been investigator-initiated, but many which have been in collaboration with our industry sponsors. So Genzyme, along with Amicus, as well as BioMarin. And in terms of our management cohort of patients, I was looking at our database. We have 203 cases with Pompe disease, 52 with classic infantile, 16 with what we call the non-classic or atypical, 135 with late onset Pompe disease. The ones which have been treated with classic infantile are 34. And just as a general trend, because this was another task that Tiffany asked me to look into, the outcome of the CRIM-negatives without the immune tolerance induction was uniformly not good. Once they've received immune tolerance induction, they have done well. For CRIM-positive babies with low antibody titers, typically the ones who have been under 6 months and without invasive ventilation at baseline have done well. For the atypical or the non-classic infantiles, they have usually done well on enzyme therapy. And when we look at the late onset patients, once they're on treatment, they usually have an initial improvement, followed by stabilization, which I still feel is an improvement, but we have had a subset of some patients who we call poor responders. So then looking at what do the long-term survivors look, because I think this is going to change shortly with newborn screening. These are clinically identified cases, but when we looked at those who were more than 5 years, when we looked at these cases at database lock, the median age at diagnosis was 3.2 months, and enzyme therapy initiation was less than 6 months, so it was about 4.9 months. And when we now look at the long term of these babies, you can see that they all grow pretty well. They're following their typical growth curves for height, weight, and head circumference. None of them have required invasive ventilation, but remember that they did not have invasive ventilation at baseline. A couple of them have had obstructive sleep apnea. They do have a persistence of motor or musculoskeletal issues, as even Nancy has shown. And again, I want to emphasize that we have a new emerging phenotype with some similarities and some differences to late onset Pompe disease. And I'm going to try and show you these.
Go. Good, and pick your head up.
That's fine.
Good.
So you can see that they still have a neck flexor weakness. You can see that there is a spinal curvature that we are seeing in infantile as well as in late onset Pompe disease. There are gait differences, and I think this starts going into the glycogen accumulation in the anterior horn cells. So you can appreciate these are infantile survivors, and you can notice the foot drop as compared to a late onset patient. And I'll try and show this to you. This is beautiful work from Laura Case from our group. And so this is really to show you the gait and posture differences. So if you look at these pictures of the infant, the surviving infant with Pompe disease, they tend to be more in hip flexion with an anterior pelvic tilt, a forward trunk lean, and a steppage gait, as compared to someone with late onset Pompe disease, where the hip extension is sufficient for posterior trunk lean with sufficient quadriceps strength. And so if you look at the stance, it's different from what we see in the infantile survivors. So our PT management really needs to be tailored based on these findings. The other part is if you look at the ability to dorsiflex, you will recognize that in the infantile survivor, over time, they tend to lose the ability to dorsiflex. So look at this video here where you see that there's a difficulty for the child to push the foot up as compared to the individuals with late onset Pompe disease, where you can see there's much more ease here in terms of dorsiflexion. And then in terms of the cardiac outcome, overall, the heart has been the star responder in terms of enzyme replacement therapy, but we have seen some of our children who have gone on to develop cardiac rhythm disturbances. They did not have it at baseline, so this is something I once again strongly suggest needs to be followed up with time, suggesting that there is probably glycogen accumulation in the conduction system of the heart. And this is showing the very nice response in terms of the left ventricular mass coming down into the normal range. As Nancy also showed, there is a persistence of facial muscle weakness, and they do have a hypernasal sound to their voice. And here I really want to show why the role for newborn screening. So this is early versus newborn treatment. I think you had the pleasure of seeing Haley, and you can see that while she's ambulating, this is from a child who was treated at 2 weeks as compared to Haley, who was started at 6 months. And once again here, the child started at 2 weeks, does have some challenges, but still can do some pretty difficult tasks as compared to Haley. She's still doing extremely well. So this is now work in collaboration with Dr. Nina Rabin, looking at muscle histology. And as you can see that in a child who is treated at less than 6 months, you still have some glycogen accumulation. If you're treated at less than 3 months, we're seeing this kind of dimorphic response with some very healthy fibers and some persistence of glycogen in some fibers. And then those treated at less than a month of age tend to have much more clearance of glycogen, but still there is some presence of glycogen even in those who are treated early. So now, in terms of the long-term infantile survivors, and I think we'll readdress this as newborn screening comes about, and I'm hoping to say that all started at ERT at less than 2 weeks of age. But in this cohort, this was less than 6 months of age. None had required invasive ventilation at baseline, and all of them had tolerized or had low antibody titers. That's less than 1 in 1,600 over time. So now let's look at the early juvenile or the atypical infantile. So this is to show you that they continue to do well in terms of enzyme replacement therapy, but they definitely do have persistence of motor deficits. Most of them remain ambulatory. And this is another young boy, as you can appreciate.
Okay, go ahead.
And so this is the experience with enzyme therapy in late onset and the importance of why we would like to continue with systematic testing. You can see a patient first trying to walk without the walker, but then on ERT is able to walk more independently. And this, I think, is a really important one, a patient who was started on therapy. And this you can appreciate on hip extension. This is on enzyme replacement therapy. The patient then came off enzyme replacement therapy and noticed her real difficulty in hip extension.
And then try your left one.
Then ERT was restarted, and you can see once again ability to do the hip extension, and then came off ERT. Look at the fourth one. You can again see a challenge. Very subtle changes, but if these are not captured carefully, we are going to miss these benefits which do occur with enzyme replacement therapy. So then Tiffany asked me to talk about the ERT start and stop criteria. I think for infantile Pompe, we need to initiate enzyme therapy at the earliest. But for the rest of the disease spectrum, I really think that the goal is to prevent the diagnostic odyssey and to treat at the earliest early signs and or symptoms. And in the US, we are fortunate that we don't have any stopping rules, and it's more a discussion with the family, the patient, and the treating physician of if a family decides that they don't want to continue to treat their child or the adult anymore. The next thing that Tiffany asked me to speak about was the role of antibodies. And so I just wanted to give you an overview that there are different scenarios. This is what we really want, what we say that do not make antibody titers. This is also good, where there are low titers. This is the sustained intermediate titers, and this is the situation we really don't like, the high sustained titers. So if the assay is done at Genzyme, anything that's less than 6,400 throughout is considered a low titer patient. And if the titers are more than 51,200 on 2 or more occasions, more than 6 months on therapy, that's considered a high titer patient. And so then we were able to show over time that if patients, irrespective of whether they were CRIM positive or CRIM negative, if they were in this category of high sustained antibody titers, you can see that they did not survive. Either they ended up on a ventilator, invasive ventilation, or were deceased, as compared to the low titer patients who had a very good overall survival. So then the next thing is how many of the infantile cases are really CRIM negative, and this would vary, as you just heard from Nancy. They do not see CRIM negative, but this is from a collective cohort from Diksha and our lab, that about 34% of our infantile cases are CRIM negative, and this is even from a larger cohort now in collaboration with many, many different physicians. From 183, it's still about 32% are CRIM negative. So the next question is, how many CRIM positive cases are at risk for making high and sustained antibody titers? And so here from the infantile cohort, about 40% of the infantile CRIM positive cases end up developing high and sustained titers. And even amongst the late onset cases, and this was in collaboration with Dr. Shozer, who's going to be speaking after me, about 10% of late onset cases have developed high and sustained antibody titers. So I think I share this with you again, and this algorithm again is part of our care of now following the patients, especially if they're CRIM negative, making an early diagnosis and instituting immune tolerance induction. And here is what have we done to ameliorate this, and different groups are doing different things, but the whole idea is that if you have a cascade which results in antibody production, if we can use agents that can target these cells that ultimately make antibody titers by preventing the development of this cascade that would make antibody titers, we can hopefully have a better clinical outcome for our children and the adults. So this is our history, 22 cases who were CRIM negative, and we have longitudinal follow-up now on 17 cases that have received immune tolerance induction. So this is just to show you, using that protocol which is now published, is even the heart, which we say is a very good responder, these are the CRIM negative cases who did not receive the immune modulation. And what you'll see is that even the left ventricular mass continues to increase over time as the titers go up. But once you immune modulate them, the titers, the left ventricular mass comes down and stays in the normal range. The same thing now is now looking at the antibody titers. These are the CRIM negative high sustained titers. You can see that the titers keep going up, and these are the ones with immune modulation. They tend to have low or no antibody titers. And how does that really translate to the outcome? You can see that these are CRIM negative patients treated with enzyme therapy alone versus the CRIM negative patients who have now been immune modulated. You can see that of the cohort, 12 of them continue to be alive. What I've marked in red is that if they start ERT at a younger age, at 2.5 months, they tend to do well, as compared to any child who, if they're initiated on therapy later, you can see that some of them are as old as 11 months, that they have succumbed despite the immune modulation. But the point to make here is that the timing of death was after the recovery of their immune system, and so it was not related to immune suppression at the time. So this is one of the oldest CRIM-negative infantile survivors, and this is courtesy from Dr. Hershkovitz from Israel. This little girl, you can see, does have some of the long-term features that we see in infantile survivors, but do remember that this is a CRIM-negative baby who was treated in the naive setting and is today alive. So now I don't have time, but I want to also talk very briefly about the high sustained antibody titers, and to say that we have a mechanism to treat this as well. And I'm proud to say that these patients are also now immune tolerant, as by the definition that you're not receiving any kind of immune modulation. You've got B cell recovery, you're receiving the antigen, which is the enzyme replacement therapy with Myozyme, and you're receiving your vaccinations. So this is a little child, I think I have shared this before, who was 14 months, was extremely sick, had very high titers, and was very hypotonic and ventilator dependent. This is him at 66 months, where his titers are less than 1 in 100. His heart has normalized, and he's now immune tolerant and off all immune tolerant induction. Just 3 slides on alternate dosing, because this is a question that has come up. I think what we are learning is that with age, there is a need for an increased dose of the enzyme replacement therapy. There are increased demands during periods of growth, and also especially during puberty. So I had shared this, and I pulled this from the meeting that we had in 2012 to show you that there was improvement of doses in a young child whose dose, what we were calling as double dose enzyme replacement therapy, of 40 milligrams per kilogram every 2 weeks. And now I'm just going to share with you that since that time, a clinical trial was done, which was sponsored by Genzyme Corporation. This data is now published of the success of alternative regimens, either using 20 milligrams per kilogram per week or 40 milligrams per kilogram every 2 weeks. And then we have some of our data, which we are ready to publish as well. This is to show you the role of the biomarkers. As Nancy showed you, this is the HEX4 or the GLUX4, and this is the CPK all going up on the 20 milligrams. And then as we increase the dose for this child, the levels of the CPK and the GLUC4 as well as the other enzymes have come down. And the reasons for the dose increase were, as you can read above, it was mainly because of a minimal improvement as well as increase in doses. And the clinical improvements were energy and endurance, decrease in the myopathic phases, decrease in sleep apnea, and decrease in the GLUC4. And then this is case 2. This is a little one from South Africa who continues to see us. And once again, you can see the similar improvement. And here you can also see a remarkable improvement in the doses as the dose of the enzyme replacement therapy was increased. So now just the advances, the adjunctive therapies. We need to find a way to get better enzyme delivery. You'll be hearing from the sponsors tomorrow. But this is another way of doing it, which is by upregulating the mannose-6-phosphate receptors. And this is led by Dwight Coburl in our team here. The idea is that if you have more of M6B receptors, you'll have more efficient delivery of the enzyme to the skeletal muscle. And so this is the work now in clinical trials from the muscle biopsies from individuals who were treated with albuterol. And this is to show you after the addition, the muscle biopsy done after albuterol was given to these patients. You can see an increase in the M6B receptor, and this also translated to improvements in the muscle biopsy before and after the initiation of the beta agonist, which was albuterol. So this has then led on to now a new phase 1/2 double-blind placebo-controlled study underway in adults with Pompe disease at Duke. We do have an IND which has been filed with the FDA, and clenbuterol is now funded by the FDA Orphan Drug Grant, and we are currently enrolling patients at Duke for this. And then in closing, we have to also look at muscle training. And as Dr. Van der Ploeg showed you, for the skeletal muscle, respiratory muscles are also muscles. And Dr. Jones from our group has been the PI for this. And I'll just leave you with two thoughts, that with good respiratory muscle training, these are even in children who can be trained. There were gains that were persistent to 3 months following detraining, so they had improvements in their MIP and in their MEP. And these results have persisted. So the point here to make is that even children can participate in this kind of respiratory muscle training. And then also in adults, this was recently published. Once again, there was improvements that were noted, and then the increases were generally durable to even 3 months after detraining them. And another point was the overuse in one of these patients in this particular study actually resulted in fatigue and the CPK going up and the patient actually having a worsening. So doing too much can also be harmful. I think we've got to recognize, to push the boundaries to as much as the individual patients can do. And so I want to close that in summary, we've had major milestones in the field of Pompe disease since the first AMDA meeting here 20 years ago. L-glucosidase alpha has been life-saving. We do have some challenges, but there are so many new therapies on the horizon. Newborn screening has really become a reality in many parts of the world, including here in the United States. And today, I think, is a day for us to celebrate the families with Pompe disease for all their courage, commitment on this journey which we've all embarked on together. So once again, I want to thank AMDA, Tiffany and Marcia, and acknowledgements to our Duke team. Thank you. And I should say,
thank you for that excellent presentation, Priya.
and also to our global investigators and physicians and others. I should not discount the global community that has been helpful here. Thank you.
Thank you so much. Dr. Benedict Schoesser.
Well, so are you fit enough for another talk in another role? Yep, I'm going up. Yes, you are. So first of all, let me really thank and appreciate the role of the House family over the past 20 years. As a newcomer to this conference, I think I have to say a little word for the full community over here, because what you did is really to develop a role model for many, many other rare diseases, and especially for the neuromuscular field. So really you can be very proud today what you did over the past 20 years. And it's a bit, therefore I put it in here, so it's the Alamo spirit, I guess. So I learned this over the few days, so that this is something very important for the history of Texas, but I think this Texanian spirit that really comes alive here in this audience, and especially in all these people working on the disease, and especially for the House family. So thanks indeed for that. And thanks indeed for inviting me as a newcomer here to this. I'd like to present you a little bit about my center. So the Neuromuscular Center in Munich has a unique history as its own, because it's the only strictly neuromuscular center in Germany. So we have a lot of in and out patients. I don't go to all those numbers. And of course, one of the key elements was always the link between clinical information and also muscle pathology. So that was the deep link for many, many years in that institute. and that gives us a lot of special information for many patients. And of course, I'm closely linked to my co-worker, Wolfgang Müller-Felber. He's working now at the Children's Hospital, and we are linked for a long time for Pompe disease as well. And of course, this institute, have you ever been to Munich? Is there one who has ever been to Munich here in the room? Oh, a lot of them. So Oktoberfest is just 500 meters from this. So you know the place, so it's really easy. So the history of Pompe in the Bauer Institute is going back actually a little longer in 1971, not 74 as laid out in the program, so I was wrong. I did another search. And this is something very unique also for the German situation. It's a semi-private founded institute because Mr. Bauer was a shoe seller after the Second World War. He made a lot of money after the Second World War with selling shoes all over Germany because there was a big need for new shoes. And his wife actually was affected by a poliomyelitis and developed a type of post-polio syndrome and was one of the first to need the iron lung. So this institute was one of the first institutions where polio patients were treated with the iron lung. So therefore we have also a lot of old experience with non-invasive and even invasive ventilation in that. And the first patient actually was picked up by a muscle biopsy in 71 by my former chief. And today we oversee something about 47 in the past 10 years, mostly adults, very few babies only diagnosed over the past years. And we were involved in all the last trials, but our main source of really knowledge is really in a lot of clinical trials over the past years in different types of diseases. We were one of the centers were included in the motor neuron disease. The Riluzole is one of the only still licensed drug for this disease, and we were heavily involved in that, and many other for myasthenia gravis and also for the limb girdles and other metabolic diseases. So at the moment we see 34 adults on a regular basis, and 14 of them were really by a fortnight infusion at our institute, and another 2 patients are infused in the Department of Neuropediatric. So I also had to have the same flow of my talk like Priya had, so I was asked to give a bit information about the long-term outcome of our patients, and I can tell you that 4 of them are not under ERT because they decide by themselves that they don't want to, because it's a too big burden going 2 times months into an institution, get the infusion, and so they decided, well, to stay apart. They will come, definitely. I think so. So we have a lot of patients with a really long history. So the oldest is now picked up just a few days ago at the age of 82. It's really the oldest we diagnosed Pompe patients in Munich. And so the poor responders, you have to keep in mind, the poor responders in our institution, they have something about 30 or 35 or even 40 years of the disease, of the burden of the disease. And if they don't respond pretty well in all those treatments, I think that is very understandable. And the rest, we have very good responders, of course, and of course there's a first year that is very important, and you can sometimes really predict, if you do have a really good responder in the first year, that he will be stabilized or even improve over the next period of the next 4 to 5 years. And intermediate responder is for me that someone who is rather stable, at least in some of the function, but not in all. And that is perhaps the most realistic picture in many of you. And if I look around here, of course, there are marvelous patients under here, the audience, but many of them, they know pretty well that not all is solved in the disease, that we still need new tools to improve and make the life better of our patients. So start and stop criteria, that's a very difficult topic for me. As a physician, I'd like and want to treat everyone I can. That's definitely a clear-cut decision. So I'm full in agreement with the American Society and also with several national EU guidelines. So if there is a symptom in a patient, I will start with treatment. and definitely on the base of a safe diagnosis, of course. And of course, I do have to assess it because it's a lot of money, even for a rich country like Germany. Think about, for the beginning in 2006, the drug budget of my department was exactly equivalent to the full budget of the Department of Pediatric. Think about this. So that's the relation, treatment, Pompe disease, treat rare disease. So therefore we have to be very careful, and we do have to assess our patients if they really do respond or not in at least every year. And therefore we started, I come back to this later on, we started to have a better European cooperation on this. So you did it pretty well over here and did it internationally, but now the situation is we have a lot of more patients to be covered, a lot of more different interests, and of course we have a very good group over in Europe. They have a really long experience, and we all are really proud to have them over here, the Rotterdam group. They gave us a lot of input, all the other centers, and therefore we created a European network called European Pompe Consortium. And here we thought it's very important to have different types of domains, so the clinical domains, patient-reported outcomes, but also other information we still need. We still need information about the survey, we need about treatment, and also we need the information about the death rate in the population. So that's still a need. Also to discuss any new treatment items with our insurance companies, with our IRB boards and things like that. So start or not start, I'd like to bring up a case to you. So this is a very nice lady at the age of 29, and since 24 she has infrequent exercise-induced myalgias and also proximal leg weakness, but only after exercise, but the rest is completely normal. There is no hint that the disease, also proven with 2 known mutation, and you have a little CK elevation in that patient. The rest is completely preserved and completely normal. So a normal clinical examination, no real signs, no real symptoms of the myopathy yet. The lung function is completely preserved. 6-minute walk is upper limit. MRI, even if you look at this, so the muscle seems to be perfectly well. No axial weakness, no axial atrophy. Diagnostic gives the right picture, so you see a reduced activity in the dry blood spot testing, and also you have the mutation field. And so it's an adult Pompe patient, of course, with a hypercycemia only. So what to do? That's really the intriguing question, and we can't really answer this at the moment. So we think that it might be perfect to start in a patient, but think about the burden you give to those patients. She's a free, completely independent lady, can go on holidays wherever she wants. There's no need for going for enzyme replacement therapy every 2nd week and things like that. So here, my recommendation, it's my personal recommendation. It's not a recommendation based on a big background study or things like that. So it's just the wait and see. It's really the classic attitudes the English do always with many of their patients and many of the diseases. So close clinical follow-up here really at 3 months, and of course we look for muscle function and for all the quick motor function tests and 6-minute walk and all the things, all the battery we do normally. And perhaps one advice is to include also a sleep lab investigation. We had this contribution from Dr. Bach today. Also, I don't agree with all the items he mentioned, but definitely we have to look for the CO2 in those patients during the night. I think that's a very important information to visualize if there's a sleep disturbance in those patients. So therefore, yeah, stop criteria, the other field. So of course, if a patient wishes to stop, and I have 2 older patients, they come up to me and say, well, I'm now 78, and I have a good life, and my life was pretty well for a long time, and now I'm 6 or 7 years on ERT, and I see that I was stabilized for many years, but now I'd like to live without you, doctor. I'd like to leave you. at least for a couple of months, and I can restart if I really see there's a decline, but I'd like to leave you alone, and you leave me alone for a while, and then we see what's ongoing. And that's very understandable. So therefore, if there's a strong wish of the patient, you can't treat, even if you have all your knowledge on the disease, all your knowledge on the patient, you can't treat a patient against his will. So if he's not agreeing that he should be treated, you should start with the treatment. So that's really my belief, a strong belief in my experience of the past years with neuromuscular disorders. And again, of course, if there's really no change at all, you tried it, you perhaps even thought about doubling dose and things like that. And you tried clenbuterol in addition, because that's something we do a lot in many patients in the neuromuscular fields. Also, there's only one proven really study on this. But anyhow, we add it as an extra help for some of the patients who do decline. So even there is, at least you have to have the discussion with the patients. Do you want to continue? Is this really something you want to continue, or do you decide to do a stop? And of course, if I see a really decline right from the beginning, even in the first year, there is no stabilization. So there's a decline in motor function, there's a decline also in the lung functions. And at least after 2 years, I also would start with the patient a discussion what to do. And there you definitely see the need for a new enzyme, for extra enzyme, for gene therapy. Also, I believe that this will take a little longer. But anyhow, I think we have definitely needs for extra treatments in those patients. So therefore, that's only 3 patients really stopped finally at my department, because the one was, he was now 82 years old. He stopped because he said, well, there's no need to continue with that. And then we have the 2 cases already reported by Priya, and also in a publication with really high sustained antibodies, and they also stopped. They didn't agree to do them on the immunosuppressant level and restart, so they decided, no, we want to stop. And luckily, it was really good, because they recovered pretty well, and now they are on the natural way of their disease. So it's not a good way, you know that pretty well, but that's something that is the decision of the patient finally. So there were some more questions. Tiffany laid out a very strict structure of the talks, and I agree. I think that's very good, because then you have something to think, and I give you just my clear answers. So what frequency do you see in adult patients for antibody monitoring? It's rare. It's really extremely rare that these are relevant antibodies. The most of them, you should look for them, of course, and it's still freely available to test that. And there's an independent test also available beyond Genzyme Company. You can do that. And of course, if they are sustained and you have in addition a clinical decline, so for me it's always, if you treat antibodies alone, so that's senseless. So you have to have a clinical decline as well. If this combination is there, then you should discuss this with the patient, stop ERT, do an immunosuppressant course, and then restart. And also, I believe that the combination of immunoglobulins and rituximab, because that declines really the B cell answer in that cell, is really something that's good, doable in the most of the patients if there's a need for this. Alternative doses. So we've heard a lot about this, and we had a long discussion, and there will be a paper on this from the European side. So I think I'm looking forward to this as well. We can't give recommendations on this at the moment. Also, there's the situation published, the data published from Priya as well. I think we need a larger study, at least for the adults. For the infants, it's different. But for the adults, before we start doubling dose or do different types of regime, we definitely need a clinical study to really have clear-cut measurements in that, and not just doing by chance. And that's something I really would like to advise and would gain common ground with all of you, that don't start in the adults upgrading the enzyme dose. I don't see the belief. So because we have some old data, there were in the lots part, also some additional data there, and they were not clear-cut that this is a one-to-one thing you can change from the animal data into the clinical perspective of the adult onset patients. So therefore be more careful, and I'd like to see definitely a clinical study with a higher dose or different regime and things like that. So therefore we don't do it, and I don't see really that we can transfer this animal data we do have into the human context. So finally, adjunctive therapies. Of course, you've heard today a perhaps rather narrowed part of non-invasive ventilation guide. So I still feel if you are a patient over here, you don't have to change your regime if you are fine with your regime. So if it works well with your lung function, there's no need to change that. So be careful about this. So every change in a chronic disease is always a danger. It's always a risk, and you have to think about what is wise. Is this risk something I need to challenge, or is it a risk I don't need to challenge? So therefore, be careful about this. That's also my advice. Sleep lab investigations, yes, I agree that they should be done in a better condition and not done by pulmonologists. They should be done by neuromuscular specialists. And then you cover really the diaphragm dysfunction and things like that. And of course, you have to integrate the physiotherapy in that. So also they have to look for lung function. They have to stabilize lung function. And we've heard very nicely about the exercise and training programs, and also I add something else. So I'm in favor also for this vibration platform access in patients. Also this, and what we definitely know at the moment for neuromuscular disease in general is it should be more endurance, but also there should be a compound of strength training as well. So that is really the combination we need for those patients, because if you want to support that your satellite cells are going into an active state, they need also to be a bit under pressure, and then they divide and do their perfect job. Really interesting, because that's an old thing from the neuromuscular field in FSHD. It was the albuterol trial, and also clenbuterol is widely used. And this has to be done in a better way, performed in really a clinical trial, and I'm looking forward for these data. Still, there's the discussion about the creatine as an extra supplement. In the neuromuscular field, we don't, or there's a disagreement in many of the players in that field that this is really helpful. So the advice is, of course, if you don't eat meat, then perhaps it would be a chance to supplement this very well. But if you are a beef eater, like I guess over here in Texas, so you don't need it. And I think artificial creatinine won't be better than the natural way of getting creatine via the beef. Anyhow, so what is the situation about Pompe disease in Germany? So that's a summary we did for the EPOC, and the total number of 60 million, of 80 millions, it's increased due to a lot of refugees coming in, so there will be also new Pompe cases coming in as well. And of course, we think that it should be in that population something about 400 to 500 patients. We know confirmed something about 300, 320 at the moment, and on treatment, so that's data from the company, are 252. That was the latest number I got. And of course, there's only up to 40 are from the infantile part, and confirmed are 40 of this, and treated in different types. I don't go to all these different data are 38, and we have up to 10 centers, but there's only 3 major centers. They really do all ages. And the so-called catchment area for a patient coming to the center is something about 200 kilometers. I think for American conditions, is this really downtown. So well, we started with this European part, and we were first 9 nations came together, and we founded this in the beginning in Naarden in the Netherlands, and then the second meeting we finalized it in a way. The foundation was in Munich in March, and that's our aims. Our major aims are rather easy, and it's very well shared with my co-chair, with Hans van der Bloch, that for us it's strongly important that we have some more industry independent standpoint for our patients. We have to save them, because now we have a lot of different companies coming in, and each and every one is tackling the right patient population, and we also have our special interests. Look at all these different types of investigator-driven gene therapies. They are on the scope now. So therefore it's good that we have a shared knowledge base, that we work together, and the thing you did over here pretty well for 20 years now, we have to start doing this on a European level to get good translation into clinical benefits. Okay, so we already have confirmed something about 1,250 confirmed Pompe patients in those 9 nations, and that, well, increases the incidence of the disease a little more than to the normally said 1 in 40,000. Might be something in between that. So this is only 9 nations, so it's not a total of things. So finally, let me stop with, from my personal opinion, unmet needs we still feel in that thing. Of course, we definitely need additional drugs. We need alternative treatments in the patients. We need to improve the delivery of the drug to the target cells. So that's not only the enzyme, but also the virus. I think it's something like the exosome approach, so particles that can cover some of the immunogenicity of the virus, because that's something we need for all the neuromuscular field. We need to discuss, I don't know about the situation over here, home infusions. That's something very important, not very well laid out in Europe. There's only a few countries, so in the Netherlands, of course, but not in Germany. There's only very few cases treated by home infusion. That's something important. And then a topic I'd love always to talk about. So for all the clinical studies, we have the moving target. The moving target are our patients, because they have their patient situation, and of course they have the special purpose of the disease, and that's ongoing. And so therefore it's so different to the former studies now. The delay is really cut down at least to half or even less than half for making the right diagnosis. So the new patient population they will start, and even if we think again about a naive study, will be completely different to the former studies. That's also something that is very important. We still need a biomarker for the disease and for the disease stages. We don't have that. And finally, I think Arnold will talk about this tomorrow again, is the better understanding of the genotype-phenotype variation, and also Professor Damasino from Italy will talk about this, about the epigenetic base of the disease. That's something also we have to work out. And we still need more principal input to think about perhaps also strategies against the principal muscle wasting in that disease. So we need more realistically think about energy supply in that disease. So we had a bit of this, so how much glycogen is still needed for getting a good power and things like that. And of course we have to think about the muscle growth in that context. So that's all what I'd like to share today with you, and thanks indeed, and keep on going. Thank you
very much. Our last speaker is Ans van der Ploeg again.
So, my job being last, and to be complementary to the rest, so I will try. Thank you all, and specifically, of course, Tiffany. Where are you, Tiff? Oh, there, over there. Thank you for having this meeting organized, because it's terrific. So the question to me, as like the others, what have we learned so far? And then what came up to my mind is, where do we want to go? Because I think that's also very important from here. Because in my view, the pioneering work has not ended yet. We have achieved a lot. But what I also realize over the years is that it is a continuous learning curve. And we need to learn more, and we have learned a lot over the last years. But we also realize that there is still room for improvement. And I always have an optimistic view, and tomorrow we know more than yesterday. And let's use this knowledge. We also have to have an open eye for innovative therapeutic strategies like we heard today. And this is not only important for patients with Pompe's disease, but also for all other patients with all other types of diseases. For example, that can be muscular diseases, but also lysosomal storage disorders. And in my view, development of a therapy for a genetic disease is a road that never ends, and I mean it in a positive way. So where did I start with Pompe's disease? And so I also digged in my closet, and I started with my thesis, and I did my thesis with Arnold. And in fact, I was your first PhD student, wasn't it, Arnold? It was. I know. No, but this is the cover of my thesis, and I thought it's interesting because what it shows is, in fact, and I have. In fact, it was designed by my brother, and my brother is an architect. And what it shows, I need the pointer. So here, apparently, I told him what my thesis was about. And so here, this is the lysosome, and the lysosome is filled with glycogen, but then you give the enzyme, and then it clears. So you have the enzyme in the lysosome. And this is alpha-glucosidase that's processed to mature forms. And here is the lysosome again, and here in the bigger lysosome you see the enzyme, or the cell, sorry, this is the cell with receptors and the enzyme in the cell and the lysosome. And this in vitro work connects with the mice, and these are the ears of the mice, and this is another mouse, and that links to the in vivo experiments in the mouse. And then he made, oh sorry, I go a little bit too quick, and then he made a labyrinth here. And the center of the labyrinth is the lysosome, and he mentioned it like this, he explained it like this, he said, yeah, and that's apparently what I explained, is that it's a continuous search that is centered around the lysosome, and it's a way we don't know exactly where to go, but at the end we get somewhere and we learn something new every day. So that's about it, and I think it's still applicable. So let's work on it, and let's find the way out of the labyrinth. And that's the solution. So, in fact, after this thesis, we had a long history on Pompe's disease. Our group cloned the gene. We generated a knockout mouse model. We did feasibility studies with the enzyme that was produced with the help of the gene. And we did feasibility studies with recombinant human alpha-glucosidase in CHO cells in the lab, and in milk of transgenic mice and later rabbits, in collaboration with a little startup company was Farming. And then we demonstrated the efficacy in mice, and finally, and that was the big moment, in 1999 we did the first clinical trial with recombinant human alpha-glucosidase from rabbit milk, and in this trial 4 infants and 3 older patients were included. So we have been involved in many trials, and what the main important trials were was the rabbit trial that was published in the Lancet, and we were also the biggest center that was involved in the late onset therapy study. And what I see is that we will continue with all those trials, and I hope that we at the end find the best medication for the patients. So I put up all kinds of companies that play a role in development of enzyme replacement therapy, and I hope that at the end we find something and or with innovative other strategies. This is the team that we work with, and the interesting thing about the team is that in fact we are a center that works with different departments that work together on a continuous basis and take care for the children and the adults. And so it includes the people from neurology and pediatrics, internal medicine, the hospital pharmacy, and also clinical genetics. And if we discuss patients, also the laboratory, for example, is involved in the patient discussion. And how I see the work on Pompe's disease is that it's translational, and that's continuous translational, and not only from the lab to the clinic, but also from the clinic back to the lab. So if you have a question in the clinic, we need to go back to the lab, and so we try to improve our knowledge and care for the patients. Our stronger strongest partners are the patients, and in fact we already have a long history with the patients, because I see that it's teamwork. It's teamwork with patients, it's teamwork with the doctors, it's teamwork also with the industry, and to find the solution for the patient. And here you see a picture of the of the second International Pompe Day. And on this day we had a meeting in the lab. It was organized by PIM. And what the patients did, they extracted DNA from strawberries. And that's what you can see over here. And this is Monica in the middle, and that's a PhD student from Colombia. Then we get a lot of data, and what we discussed already today is the IPA survey that was started in 2002 and now encloses data from many patients, over 400, and gives us a lot of information. And thank you all that you participate in this service. It's very important that we learn about the patient's point of view via this survey. And we also govern at Erasmus MC is the Pompe mutation database, and that also can be done by the help of many, because all the doctors help us to get the information on the mutations and send materials, and that made it a success. And with this we can find out which mutations have a severe impact and which have a milder impact. And what is circled is the IVS1 mutation, and it is the most common mutation in the late onset patient population. But I think Arnold is going to talk about it tomorrow, so I don't want to do it. What's also the nice thing about the Netherlands, and I already mentioned it when we had the discussion about the training study, that the Netherlands is a small country, and in fact, and I think that's also something that we something that our colleagues organize, in fact, that we see all the patients in the Netherlands with Pompe's disease. And since 1999, we've seen in total 193 patients, and that are 128 adults, 37 juveniles, and 28 classic infantile patients. Currently, we see 150 patients actually on a daily basis, and 127 of these patients have ERT. Now you can see the figures below. There are also patients that we see from abroad, and now and then they visit us or they come for a single visit, and overall 24 patients have died, and that also includes infantile patients that we've seen. Our hospital's pharmacy makes all the infusion for all the patients in the Netherlands, and that's for 127 patients. And what I calculated is that they make infusions with 100,000 vials per year, and 3,500 infusions, and we supervise those infusions. I think about 80 to 90% of the infusions is given in the home-based situation, and it's done safely, and it's going very well. And what we have a system where the nurses, we have a home-based organization, and that works together with us. They do the infusion, but they are trained by us, so we give a course, and therefore I also put Hannerike there, because she plays a major role in giving those courses and organizing it. And when these infusions are given at home, we always have a telephone, so that if there is a serious problem, or if there is a minor problem, they can call us. Of course, if there is a serious problem, they have to call the somebody who can give emergency care. But in fact, it goes very well, and we have rarely a problem in the home situation, and mostly we can solve it. Then we also have two planners, and these are Wilma and Vanessa, and these are secretaries, and they plan the assessments for the patients. And we have a standardized protocol and that they follow, and that's also something I would like to tell, that it is really extremely important that patients are followed. And Benedict already indicated that we have agreed upon a minimal data set. Of course, it doesn't have to be that extensive as we sometimes do, but at least, and it's also important to have an agreement on this set of assessment, because when one does a 6-minute walk test and somebody else does a handheld dynamometer, you can't compare. So that's extremely important. And I think that is that's what I feel is that is a responsibility of the doctors, of course, to follow the patients. But I think it's also a responsibility of the patients that they do that together with their doctors, because these therapies are quite expensive, and and the diseases are rare. And if we don't work together on these data collection, then we will not get any further. So I think it's extremely important. Then to the patients. What's very special is that the first infantile patients soon become adults, and I would like to introduce you to my first infantile patient here at the age of 2, and I go a little bit quickly. And yeah, of course, this would never have happened if we wouldn't have treated the patients, because all our classic infantile patients die before the age of 1. And over the last years, at least since 2006, we always have discussions with parents when we start ERT, and there are always parents that in mutual agreement decide not to treat, and all these patients die within the first year of life. And I leave the last video for now, because here is my patient now close to adulthood, and that's what happens, even in the Netherlands, or maybe specifically in the Netherlands, because the children are so tall. So, but there is also a lot of work still to be done, and this is maybe a little bit a complicated slide, but I hope that I can show you. What I did in this slide is that I put together the data of the larger studies that have been done recently, and what you can see here, I will use the pointer once again, if I can find it. This is the 1602 trial. That's the pivotal trial for the classic infantile patients with the Priya as a leader. And here, these patients were followed until 3 years. Then very recently, I think a month ago, the UK has published, Alexander Broomfold as first author, has published the data from the UK population. And then in the beginning of the year, Andreas Hahn has published the data for the Germany population. And in the last column, I've put the situation for the Dutch population. And if I go to, a little bit, what was it? Here, yeah. If I go first to survival, then we see that the survival ranges in the different studies from 57 to 82%. And you see here the current ages of the patients, and here up to 17 years. Ventilator-free survival 40 to 68%, walkers 39 to 82%, and persistent walkers 26 to 60%. And then of course, I know the best what we did, and I thought it's good to show you what we did over the years to improve the outcome of the patients. Because, in fact, if you look now at this data, it seems that we have the best results. And I thought maybe we can give a closer view what we did over the years. And in fact, I think we can split this up in 3 periods. The very first trial in 1999, and then we were not aware of what we needed to do and what we could expect. And we also included patients who were very severely affected, who could not move arms and legs. And in fact, the first patient was already ventilator dependent while we started ERT. And if you see at the end, still 3 of the children survive, but you see that only 1 is able to walk, and CRIM-negative patient died. Then from 2006 to 2009, we treated patients with 20 milligram per kilogram every other week. And you see here the survival is 66%. But if you look at the persistent walkers, it's 33%, and CRIM-negative patients died. Since 2009, we treat our patients with 40 milligram per kilogram per week. Oh, thank you very much, Ria. And you see that the survival is much better, and persistent walker at this moment 83%, and also the 3 CRIM-negative patients have learned to walk. So it's just an indication. I don't want, because that's also something I want to tell. what I've learned over the years, nothing is black and white. There is always, and it would be so easy if you could say, if you do it like this, you know for sure what comes out, and that's not true. What is our current treatment in the Dutch situation for infants with Pompe's disease? That's 40 milligram per kilogram per week, and more recently, and we did it in the last 5 patients, we also immunomodulate if patients are older than 2 months at start of ERT. And then we provide rituximab, methotrexate, and IVIC, that's immunoglobulins, IV immunoglobulins. We start immunomodulation independent of the CRIM status. We don't have the CRIM status at start of therapy because we want to start very early once we know the diagnosis. And what's also very important is what threatens these patients is the respiratory condition. And what we found, if you look at, you do a fiber optic endoscopic evaluation of swallowing, that's a fiber optic, you look at the vocal cords, then we were surprised to see that these patients have feeding around the vocal cords while these children don't notice. And this is something we see in infants, but you may also recognize this as an adult, because we also found in the adult population that about 25% of the population has bulbar weakness, so that it now and then is difficult to swallow. But what we also decided is that we have to be more rigorous. And because we want to have a good future for the children, and we feel that if infants need a ventilator very early in life, that their prospects are very poor. And we discussed that beforehand with the parents, and if they need a ventilator in the first year of life, we don't do it. And we don't have any problems with that, not with parents. They agree. It's always difficult, of course. It's difficult discussions, but they do. Here I show you the comparison of the aims of 4 children that we treated with 20 milligram per kilogram every other week, and 4 with 40 milligram per kilogram every other week that are CRIM positive patients that were not immunomodulated. And what was shown is that in the 20 mg per kg group, 3 of the 4 learned to walk, and 1 lost the ability to walk, and 1 became ventilator dependent, while all the 40 mg per kg children, although they started later, learned to walk and did not use a ventilator. And what we also noted in the 20 mg per kg group, that 3 of the 4 children had a lot of respiratory infections, which prompted us at a certain moment to increase the dose. And what we've also learned is that it's less effective to start to increase the dose at the later stage than when you do it from the beginning. Sorry. That dosing is really an issue has also been shown by the preliminary data from our EPOC study. And what is shown is that, in fact, this is a combination from the German and the Dutch data of more than 60 patients, and it shows that many, many different dosing regimens are applied. So this really needs further investigation. And what's also a point, if we look at what is the effect of immunomodulation, what's the effect of dosing, it's frequently a mixed bag. So, and one of the discussions is whether immunomodulation, whether higher dose also leads to higher antibody titers. I think this needs further investigation, but what we see here, the blue triangles are the patients with a higher dose and the green with a lower dose. And I think these, no. And what we see here is that there is also a relation with age. So this needs further investigation. And to show you here, this is one of the CRIM-negative patients that has not been treated with immunomodulation, and this is one of our youngest patients. But also there, we need to do further follow-up and study. Of course, it also has consequences, and I think I need 5 more minutes. It also has consequences, because if you increase the dose, also the costs go up. And that's of course a problem, and I completely agree in that respect with Benedict, that we really confine the increasing of the dose to the infant, and that increasing the dose in adults has a lot of consequences that we can't oversee at this moment. So if we look at the outcome of infantile patients, it's determined by various factors. The age of start of therapy is important. The severity of the disease is important. Gram-negative patients have a poorer prognosis. Respiratory infections are always very dangerous for the children. And what, in my view, affects possible is positively is dosing. Timing of the dosing is important, and also high antibody titers play a role. Mental development, we need to follow this up in the future, and this is a study up to 12 years and 10 patients which show that the mental development is normal to mildly delayed. Then in short, something about the adults that we follow. We see a total number of 109 Pompe patients at the moment, of which 7 are asymptomatic. And that's also something I want to say. It was already mentioned earlier. If a patient doesn't have any symptoms, we don't start treatment, and we do watchful waiting, and we follow the patients on a regular basis. What's also important, and this is a study of Nadine van der Beek and Juna de Vries in adults with Pompe's disease indeed, is that if you want to know the effect of enzyme replacement therapy, it's also very important to know what happened before. And what this study shows is the effect of enzyme replacement therapy on the muscle strength. Before here is a significant decline. Here enzyme replacement therapy is started, and then you can measure what happens thereafter. And of course that is important how it works. Here you see the cumulative data of 69 patients, and what we see is that there is variation in response, and that if we look at the muscle strength, we found that 91% of the patient was a responder, where we differentiated between good, moderate, and non-responders. If we look at the FVC upright position, then we had 84% responders, and in supine position, 61% responders. And this is the analysis of the data with a median follow-up of 2 years after start of therapy and about 40 months before start of therapy. What plays an important role in Pompe's disease is the diaphragm, and what has been shown, since there is a difference in pulmonary function in sitting and supine position, so you always need to evaluate also the pulmonary function in supine position, is that the diaphragm is extremely weak, and I saw also Barry also just showed it. And what you see here is an MRI of the lungs, and the red is where most of the air is, and you see that there is less volume in patients with Pompe's disease. That's the lower part. And I would like to show you this videotape. In short.
Let this be the last.
Yeah, it is virtually the last. You see here the displacement of the diaphragm in a healthy individual, and here in a patient with Pompe's disease, and you see that the diaphragm hardly moves. And that's also a point, what we learned from peripheral muscles, that if the muscles do not work anymore, then it's very difficult to get them started again. So I think you need to treat this diaphragm. That's what I think that we need to focus on, to treat the diaphragm before it has come into this situation. So we also, if we look at the effect in adults, we've seen various effects on distance walk, muscle strength, pulmonary function, and with the help of the IFA on survival, participation, fatigue, quality of life. And the best response is seen during the first 2 years. But there is also variation in response with good, stable, and deterioration. And what we've also seen, that the effect on the muscle function and on the pulmonary function doesn't need to go hand in hand. Thus there is variation. Role of antibodies seems to be less important in patients, in adults with Pompe's disease, and I agree with what Benedict just concluded. We just did an analysis in 73 patients over a period of 3 years, And PIM played an important role there. And in fact, we could only find a significant influence of antibodies in one patient who had a very extremely high titer.
Hans, I think I'd like to ask you to come to an end because you're going to be up here. You're going to be sitting up here answering questions.
I'm ready. Is my last slide?
Come and sit.
Yeah, thank you.
With the other...
May I do one little thing? Because I think this is really... Because, yeah, one little thing. Because this, in fact, I received, this is a yeah, it's geborduurd. How do you call this in English? I don't know. What? Crusted? Crusted. Oh, it is crusted, and it's made by Diane Eggers. And what she made it is beautiful. And what she said is the most precious things in life aren't things. And I think that's really a message for us as a doctor, because I think we need to know from the patients what's precious for